I've been amazed at how many advances we've seen with people with vision problems. And we know about cataracts and we know about a lot of things that are pretty commonplace. But we're always looking for specialists in this field of ophthalmology who are doing things that are more cutting edge. And we're fortunate to find Dr. Edward Uchiyama, who is with he's what we call retinal surgeon and a specialist. And he is with a group that's called the Retina Group of Florida. And I heard him speak over there at the Broward Health Imperial Point, and I was very impressed. So we asked Dr. Uchiyama to come and talk a little bit about, well, we're going to ask him about himself first, but then to talk about what's going on and who are the people who you really are helping. So let's first start with you. So you told me you were from Boston, which we were saying, you're glad to be down here. But you went to a medical school there?
So I'm originally from Peru. That's where I grew up. I went to medical school there. And about 11 years ago, I moved to the States. I came to Dallas, Texas. I spent there about 8 years training. I did research training. Then I did my ophthalmology training, followed by a fellowship in retina surgery. After that, I decided to do one more year of training, so I moved to Boston. And I did a training in uveitis, that is inflammation of the eye. And as you said, I'm so happy I'm here today, as opposed to being in Boston.
Right. Well, I'm happy you're here today, too, to be on a radio show, because we know a lot of people listen. They learn so much from the doctors. Years ago, Eduardo, people didn't really get a chance to talk to doctors. It was they got into a doctor's appointment, and whatever the doctor said, that was it. But now I know that you're seeing some differences because they are hearing radio shows. They're watching television. They're getting things on the Internet, So they always like, though, to hear a live being so that they know what's going on. I just want to go back to being Peru. My daughter, when she was 13, got a chance on an international exchange, it was outside of Machu Picchu, but it was, I forget the city, what the name of?
Cusco.
Yeah, Cusco. I'm sorry. Thank you. Cusco. So she stayed there, and it was a life-changing experience for her. So it was very, very interesting. So, yeah, Peru, that's one place of all the places. Been to a lot of places around the world. I've never been to Cusco or, to Machu Picchu, which is something I'd like to see. In fact, just getting off the subject, I have friends who go there, and they do a lot of archaeological digs. And there are a lot more Machu Picchus. I don't mean Machu Picchu, but there are a lot more they're finding, and you know that. It was quite a culture.
It was. You should go.
I am. I want to go. So you should be very proud of that. Okay, well, let's get now into vision. So how does someone know that they have a problem with their retina?
Well, there are certain risk factors. The most common problems that affect the retina here in our country are diabetes and macular degeneration. So one of the things that we tell our patients when we educate other physicians in other specialties are if a patient has diabetes, even if they don't have any ocular problems, any eye complaints, they should be seen by an eye specialist, by an ophthalmologist, at least once a year. Other common problem is macular degeneration. Macular degeneration is a disease that affects our older population. It starts at age about 50, but it's more common after 60 years of age. And again, this disease doesn't give problems at the beginning. So the patients may have perfect vision, or what they consider perfect vision. And if they don't get their eyes checked, they will never find out that they have macular degeneration, and that there are things that they could do to prevent or to decrease the rate of progression of those diseases.
So you as an ophthalmologist can see someone when you're having just a plain yearly exam that they're either on the verge of it or there's something that's happening, and you can help them before they have full-blown macular degeneration.
Correct. What I like about my specialty is that we're able to see inside the body. So many times we've had patients who come to the clinic for whatever reason. They have a little bit of blurry vision, and we take a look and we say, hey, do you have diabetes? Do you have high blood pressure? And they're like, no. When was the last time you saw your doctor? They say years ago. And we send them to see their doctor, and voila, they have diabetes or hypertension or other diseases. So it's very important that they keep their checkups with their eye doctor.
That's very good advice, yes, and we want them to have checkups with their primary care physician, and there are people who do that, and it's really very beneficial. So I always like cutting-edge medicine. I put on symposiums with lots of doctors who are doing unique things, and, of course, I was talking to someone the other day, and he told me he was a heart transplant patient, and I looked at him and I said, I never met a heart transplant patient before. I mean, years ago, that wouldn't have been probably even possible. But it's really excellent now that we have fine surgeons, fine science, and we're excited about it. But the vision, and I asked Dr. Uchiyama when he first arrived at the studio, I said, is it possible that we'll ever be able to have retina transplants? And so what did you say?
I think that's going to happen at some point. What many people are working on are special devices that are implanted in the back of the eye, under the retina, basically under the macula, that is the central part of the retina. And those devices are helping a very small selected group of people who have no vision, mainly, to be able to see some like pixelated images. I always do the analogy. It's like in the 70s when they started doing the cochlear implants to help people with hearing loss. At the beginning, people didn't hear the way we hear, okay? They were just hearing noises. But there was something. Now with the newest technology in that regard, people are actually able to hear, okay? You can talk to them. They will answer. I think that in a few decades, probably we'll get to that point in terms of retina implants.
Why is it going to take so much longer for a retina implant when you think it's such a tiny little organ compared to heart and kidney and lung?
I think that's what makes it difficult. It's so small. And if you think about the retina, in the retina you have millions of cells, and each cell has different functions. So it's not as easy as just to replace an area. So it's going to take time. It's going to take time, but hopefully we'll get there.
Yeah, well, I didn't share this. I don't think I shared it with you. My husband has macular degeneration in one eye, and I guess it's wet because he gets a shot once. He's getting a shot every month. Now it went to every 5 months, then once a month. Then it went to 5 weeks, then 6 weeks. Now it's at 12 weeks. It's really working. Mm-hmm. And he doesn't have it in the other eye, which is amazing. So he manages, but he does need lots of light.
Correct. The problem with macular degeneration is that it affects the central part of the retina. The macula is the central part of the retina. And that's the area of the eye that helps us see in the central part. I mean, that's what helps you see faces, what helps you read. People with macular degeneration, even advanced macular degeneration, they still have their peripheral vision. But the central vision is the one that is affected. 10 years ago, we had some type of treatments for macular degeneration, but they were not very effective. We were doing lasers, but people were just not getting better. Over the past 10 years, there's been a lot of research going on in this subject. And now we have 2 medications that have been approved for this condition. And for the first time, we're seeing actually improvement in vision in patients with macular degeneration. The problem is that the medications don't last forever. So as you were saying about your husband, we have to repeat the treatments. Some people need the injections once a month. Some people need injections once every 2 or 3 months. And every patient is different. And that's what we do in our practice. We assess the patient and then we try to give them the best treatment that fits their disease.
Must be exciting for you as an ophthalmologist because probably when you went to medical school, even though you are young, they didn't have a lot of this. And you can imagine ophthalmologists who've been practicing for 40 years. This must be like a carnival for them. I mean, a great thing. My guest is Dr. Eduardo Uchiyama, and he is what we call a vitreoretinal surgeon, but let's just say retinal surgeon. And you say a uveitis?
Uveitis.
Uveitis. specialist. I'm going to ask about that in a minute. You can reach Dr. Uchiyama at the Retina Group of Florida. They're located in Fort Lauderdale, right next to the Imperial Point Broward Health. And you can call him. Just get your pencils out. Remember, this is Pencil Talk Radio. It's 954-776-6880. That's 954-776-6880. And they really have locations all over South Florida, which is pretty exciting. So I think that people who are listening to you, I'm sure, are going to say, wow, I better really call and see what needs to be done. But let's get in. What is uveitis?
Uveitis is basically inflammation of the eye. The eye has several layers, and those layers can get inflamed due to different reasons. Sometimes infections, sometimes autoimmune conditions, sometimes we don't find a reason, and we call it idiopathic. And that's the field. The field of uveitis is the field that treats with those types of inflammation.
So people can, I'm sorry, if they maybe eat certain kinds of foods, that are very healthy for eyes, and I've heard about some of those. And then the other thing would be probably exercise, and then be not smoking. We know about that. As an ophthalmologist, and for people who are smoking, and I know a lot of people who are still smoking, which I can't believe. Now they're working on these other things, aren't really cigarettes, but they're still getting nicotine. What does it do? I would think for the eye, it's more serious than anything else, because you've just said about the cells, everything's so tiny. Talk about that.
Well, smoking has an effect on the blood vessels. And if you think about the blood vessels in the eye, we're talking about tiny blood vessels. Okay, so the effect would be probably a little worse than on other parts of the body. We know that smoking will make people with macular degeneration have a probably faster progression, and people with diabetes also will have the same problem. So there's just so many things you could do to try to improve your ocular health. Not smoking or quitting smoking is probably number one in my list. Eating healthy, green leafy vegetables, we should all do. Doing exercise, that also helps. Wearing sunglasses with UV protection, that also helps. But if you're a smoker, then you should seriously think about quitting.
Would you go back to the UV, and let's go back to the sun, wearing sunglasses. Tell us what actually happens. Why is that necessary?
Well, the radiation from the UV light will actually cause damage to the cells. It causes oxidation, and it can cause damage to the surface of the eye. That's not my specialty, but that's why sometimes you see people with small growth on the surface of the eye. We call them pterygiums. It could also affect the development of cataracts, and it could also affect the back of the eye, the retina. So it's important, especially in an area like sunny South Florida, that we should all wear sun protection when we go out.
Do all sunglasses have the correct UV? Or, how do you know what to get?
Usually they have sticker on it, and they say UVA and UVB. As long as they say those two, I think you're protected.
Oh, this is very good information for our listeners. So make sure that when you buy sunglasses, or you have sunglasses made for you, that they have UVA, UVB protection. And you should only wear them. What if you're driving in the car? It's probably just as important.
Correct. I wear them all the time. It's important. It lets you see better as well, and it protects your eye.
Fine. Well, and how young? Children. How young should children start wearing sunglasses?
An analogy would be the same way we use sunscreen for the skin to protect your skin. I think the same way we should wear it. We should wear the sunglasses to protect our eyes. We know that, for example, for skin cancer, it's not that you're getting skin cancer from just one-time exposure to the sun. It's a chronic exposure that will cause some cells to change and become malignant. Same thing could happen in the eye. One thing I forgot to mention is that people could also get a type of cancer under the retina. And one of the risk factors for this, one could be genetics, but the other one is environmental. And the environmental factor is sun exposure.
So you've seen people with cancer of the retina?
Correct. Cancer of the retina. In this case, the cancer I'm talking about is under the retina.
Under the retina. And how would they know they had it?
Usually they don't.
So it's from an examination?
Correct.
As a ophthalmologist, you'd be able to see that in your examination?
Correct. The same way people have freckles on the skin, some people develop freckles in the eye, on the retina or under the retina. And what we do is we just keep an eye on them. We make sure they don't grow. And if they're growing or they show other signs of malignancy, then we will have to do certain things to try to diagnose them and treat them.
Sounds like your organization is a specialist in this, because sounds rare. Is it rare?
The cancer in the eye is rare. We don't see many cases. The presence of freckles in the eye, in the inside of the eye, is common.
Really?
It's common. But it's like having a freckle on the skin. It doesn't mean anything. You just have to pay attention and make sure it doesn't change. And if it changes, then you have to go to the specialist.
Just getting off of the retina a little bit, but how about people who, I notice some people are using drops all the time. Is that for glaucoma? Is that just because they have dry eyes?
So there are different ways to treat ocular conditions. The most common way is using drops. And the drops could be used for, if a patient has dry eye, that is a very common. Patients get those sticky eyes, burning sensation, sometimes blurry vision. Those are the symptoms. Gets worse probably when they are exposed to air conditioning. There are some over-the-counter drops called artificial tears, and people use them 3 to 4 times a day for comfort. Other people who have glaucoma, as you mentioned, they have problems controlling the pressure inside the eye. That is different to the blood pressure. It's just the pressure inside the eye. And one of the first lines of treatment for this condition is to use drops as well to lower the pressure in the eye. Some people with uveitis, for example, what I do, they develop inflammation in the eye. And depending on the severity of the disease, we use also drops to reduce the inflammation. So there are different types of medications that come in a presentation in drops. Well,
I know that you're not a veterinarian, but I have a dog that has dry eyes. And I didn't know that, but he's gone. They actually have an ophthalmologist, a veterinarian ophthalmologist, what they wound up sending me to. And so twice a day, I put certain drops in there. And then I put also, it's a gel that you can buy in the drugstore, and I put that in too. And you know, it's interesting, and while I have you here, I'm going to take advantage of you. They make me put a warm compress on fine before I put the drops in. Why is that?
And that's the same treatment we use for humans as well. Because what we do is, and again, this is not my specialty, but I was trained on this too before I became a retina specialist.
Good.
We have a layer called a tear film. It's an oily layer that covers the eye. And basically it protects, it helps to increase the moisture of the eye. This layer, again, is an oily layer. So the oil comes from the eyelids, from our eyelids. Sometimes in people with dry eye, the oil material is a little too thick. So by using warm compresses, we liquefy that oil, that fat, a little bit, and it comes out of the lids a little easier, and then goes to the surface of the eye and keeps the eye protected.
Well, so I'm being a very good dog mommy. But, you know, it's funny, and she likes it. It's a little Maltese and puts it on, and she just sits there so quietly, and I have to make sure it's not too hot. I put it on there, and she would stay there probably for 5 minutes with that if I would let her. It's very interesting that she gets the gel. So, and it's been not improving. I guess it's a matter. I suppose some of these diseases, it's just not getting worse, but at least it's staying the way it is, and that's...
Yeah, in many of the conditions we treat, our main goal is not to cure the conditions, but first to try to control them so they don't get worse, and second, to improve the quality of life of our patients. I know, for example, in macular degeneration, with the technology we have now, I'm not able to cure a patient, but I have a very high chance of maintaining useful vision, as opposed to 10, 20 years ago when we didn't have a good treatment. When we had a patient with macular degeneration, we just said, I'm sorry, because we knew that patient was going to go legally blind, was going to become legally blind. Now with the medication we have, we're able to fight the disease better than in the past.
So then this is really cutting edge medicine.
Correct.
I mean, and eventually you will be able to transplant. You have to call me up once you do your first transplant, because of the retina, because then we'll talk about that. But and let's talk about children. What diseases? Now, are there pediatric ophthalmologists? So if it's a child, would they be going to you or to someone like that?
So most of the patients that we see, especially children, they're first seen by either their ophthalmologist or their optometrist. And yes, we have specialists who just see children. Sometimes they develop retina problems too, or uveitis problems, and then they are sent to us. But the most common problems that children develop are crossed eye, for example. That I don't know if you've seen patients with that, lazy eyes.
Yeah, crossed eyes, yes. And I know there's a person that does exercise for that. Mm-hmm. I know of someone that does it. Is that what you do? You have, or you refer to someone like that, or?
I don't treat that, mm-hmm. But I know that the pediatric ophthalmologist, they do sometimes with surgery, sometimes with patches. So there are different ways to treat that.
Right. It is interesting that now we know that there's a muscle there, and so I guess you have to reverse what the muscle's doing.
Correct.
And so you're putting on eye patches and different things. Well, it's a very interesting profession and science. Here you're in medical school. What made you think that you wanted to get into the field of ophthalmology? Tell me it was a father or uncle or something.
No. Well, I have an uncle who is an ophthalmologist. Well, he created a good impression.
I'm sure.
Me, but it's the mixture of seeing patients in the clinic, because we spend most of our time in the clinic, probably 4 days a week. We're in the clinic seeing patients, but then we also do surgery. That I do surgery probably a day a week. And it's something about the mixture, right? We can see the patients. We get to know our patients very well because, again, for several conditions, we see them every month. So they see us more frequently than they see any other doctor. And the type of surgeries we do is microsurgery. There is something about being able to fix something with your hands and seeing the improvement in patients' quality of life. I think that mixture of seeing patients in the clinic and doing surgery was what got me into the field.
It's funny. I've had orthopedic surgeons and other kinds of surgeons on, and brain surgeons, and they all talk about the aha moment that made them decide to do something. And something that I'm doing along with my husband is something called science care, where we donate our body to science rather than having cremation or any of the other things. And I was wondering if did you ever use real eyeballs? You must have in your when you were going to medical school.
During medical school, no. But during my training as an ophthalmologist, we used to practice surgery on our wet labs using pig eyes. Not human eyes, pig eyes.
Pig eyes, are they similar?
They're not exactly the same. They're a little larger, but for the type of surgeries we were learning how to do, they were good enough.
Mm-hmm. Well, but I always ask the doctor, the doctors may even become my friends. So how'd you like your, the body that you worked on all your first semester, your second semester? They said, I fell in love with it. I mean, it was mine, and so it was it was very important. But you're saying that you don't really get to have an actual head with the eyes.
We did, but it's a little difficult to maintain the eye for as long as it takes. When I took anatomy, as you were saying, we had our body where we did our dissections and we learned from it. But I really don't remember that there was an eye that we could learn from.
Interesting. Yeah, because, we know about, I was working with orthopedic surgeons, and there are about 10 of them that go to this laboratory, and they all practice on, the new equipment that's being given to them to use for their knees, for the hips. And so I was thinking about the eye. Well, that's a very interesting observation, as they say. So when you're talking though about the retina, there are, whether it's the retina or not, there are people who are genetically, I guess, their retina is very good. I mean, it comes from the genes, doesn't it? That's very, no one had a problem, and so they don't have a problem, compared to other people whose parents and grandparents had problems. So do you see a lot of that? I mean, is it really genetic, what happens to the eye?
So I think genetics play an important role on different diseases. For example, they play a role in macular degeneration. If your parents, either your mom or dad, have or had macular degeneration, probably you should get your eyes checked at a younger age, because we know that family history is a high risk factor for developing macular degeneration. There are other diseases like retinitis pigmentosa.
And what is that?
It's a disease when there is affects an area of the retina that is in charge of basically seeing the light. It's called the cones and rods. It evolves over time. It takes many years to have their full effect, but it runs in families.
Well, this has been an excellent, for me, a lot of knowledge. Dr. Eduardo Uchiyama, who can be reached by calling 954-776-6880. He is with the Retina Group of Florida. Thank you so much for being with us, Dr. Uchiyama.
My pleasure. Thanks for having me.